to 30,000 new cases per year diagnosed as a breast cancer, apart from which metastatic breast cancer occurs around 40 to 50% or more, even more percents of the initial incidence. So Indian Council of Medical Research and National Institution of the Cancer Prevention and the Research Center has published in 2018 that in India, breast cancer accounts for 14% of all cancer in women, and new cases were above 1,62,000, where more than half of the patients dies from the breast cancer, that is 87,000 and above, and beginning in early age of the 30s and peak at the age of 50 and 64 years, 1 in 28 women likely to develop breast cancers during our lifetime, and 1 in 22 women in urban and 1 in 60 women in rural areas of the India develops breast cancer in our lifetime, where metastatic breast cancer in 2019 in India, the incidence rate was around 25%, and overall 5-year survival rate was 22%, and the 10-year survival rate decreases to the 5%. So regarding the Nab-Paclitaxel, the Nab-Paclitaxel is an albumin-bound non-particle formulation of the paclitaxel, which is a solvent-free colloidal suspensions of paclitaxels and human serum albumin that exploits the physiological transport properties of the albumin. The nanoparticle drug delivery system eliminates the need for the toxic solvents like chemophore through binding the paclitaxel to the albumin. This therefore elevates the limitations of the paclitaxel dosing, need of additional pre-medication, and thus affecting overall drug efficacy. Moreover, albumin binding to the glycoprotein receptor 60 on endothelial cells thus facilitates the passage of paclitaxel from the bloodstream to the underlying tumor tissues. And as an approved indication for Nab-Paclitaxel in metastatic breast cancers, after failure of the combination chemotherapy for metastatic disease or relapse within 6 months, or the patients when anthracyclines are not indicated, for them the Nab-Paclitaxel has been used frequently, and it is used in all types of metastatic breast cancers patients with estrogen receptor and progesterone receptor positive, HER2 positive and HER2 negative patients, even in triple negative patients with HR positive and HER2 negative with visceral crisis patients also, and HER2 negative and either hormone receptor negative or hormone receptor positive with endocrine therapy refractory patients. Another progressive with no clinical benefits after 3 consecutive endocrine therapy regimens or with symptomatic visceral disease. And it is also used in advanced CA breasts who have not received prior chemotherapy for metastatic diseases. Apart from that, it is also used in advanced metastatic non-small cell CA and pancreatic adenocarcinoma patients with another combinations of the carboplatin and other modalities of the treatment. So the advantages of Nab-Paclitaxel is Nab-Paclitaxel achieves improved and targeted drug delivery to tumors by exploiting the following natural properties of the albumin. Nab-Paclitaxel specifically bind to glycoprotein 60 and facilitate caveolin-mediated transcytosis to enhance delivery across the blood vessels, endothelial cells, thus transporting paclitaxel into extravascular space to the tumor cells, resulting in an advantageous pharmacokinetic profile. Nab-Paclitaxel NAB technology increases the paclitaxel retention in the tumor interstitium by association with the albumin binding protein SPARC, that is secreted protein, acidic and rich in cysteine. Nab-Paclitaxel increases paclitaxel delivery and activity to the tumor 4-5 folds because it combines with albumin receptors through the endothelial cells. Another advantage of the Nab-Paclitaxel versus standard paclitaxel is the increased rate of transport across endothelial cells layers, greater and faster tissue penetrations, and slower elimination of the paclitaxel. Nab-Paclitaxel also demonstrates increased intratumoral delivery and retentions, resulting in 33% of the higher intratumoral drug concentrations. The infusion time of the Nab-Paclitaxel is 30 minutes, and its administration is most convenient to the patient. And regarding Nab-Paclitaxel, different clinical trials has been conducted between 2014 and 20 years. And for metastatic CA breast, almost 64 trials has been conducted. And in 2020, there were no trials conducted because due to the COVID crisis and other crises. And there are lots of still ongoing trials in 2019, as shown in the slides. So NABUCCO trial, actually this NABUCCO trial is approved for the treatment of metastatic breast cancer after failure of the first-line treatment or when anthracyclines are not indicated. So this trials, this is the prospective multicentral study, and it has been started in April 2012 till the April 2015, and different 120 institutions in Germany were enrolled in this trial, and around 700 patients were enrolled for these trials. The main primary objective of this trial is time to progression, and secondary objectives were overall response rate, survival rate, and safety and quality of life. So the age 18 years and above age were enrolled in this trial, and the median age was median total age was 62.3 years, and 54.8 age group were less than 65, and 72.6% were of more than 65 years. And along with total 70.2% had concomitant diseases, whereas 63.1% has shown in the below 65 years age, and 80.1% has shown in above 65 years of age. So the more common site of metastatic was the bone, followed by liver, lung, and lymph nodes, etc. And hormone receptor positive and hormone receptor HER2 negative were around 58.4% total percent, and among them 60.8% were of less than 65 years age, and 55% were of more than 65 years age. And triple positive cases were total were around 10%, and below 9.4% were 65 years, and 10.7% were more than 65 years age. So regarding treatment outcome, Nab-Paclitaxel in first-line treatment, 7.1% of the patients has median time to progression, median time to progression months were 7.1 months, and median overall survival months were 19 months. So same as hormone receptor positive and HER2 negative cases were 407, and median time to progression month were 6.2, and overall median survival months were 15.7 months. As for triple positive cases, 8.6% were the median time to progression months, and 22.3 months were median overall survival months. So regarding the best response treatment, Nab-Paclitaxel in the first-line treatment, overall 46.1% were overall response. 46.1% of the patient had overall response rate, whereas 27.9% have stable disease. And with triple positive hormone receptor status, overall survival rate were 37.7%, and stable disease rate were 30.4%. So it has been administered both weekly and tri-weekly regimen basis. And frequently reported grade 3 to 4 adverse effects were moreover equal to the 1%, and 7.9% of the patients has found to have neutropenia with WBC count decrease, followed by peripheral neuropathy and gastrointestinal disorders, followed by fatigue, general disorders, and administration site conditions, and infections, pain, and etc. So Nab-Paclitaxel therapy and the treatment modification in the total populations in subgroups receiving tri-weekly and weekly basis patients, and it has found that weekly Nab-Paclitaxel regimen is far much better than tri-weekly in terms of the less toxicity, good response to the treatment, and with no dose modification required, and safest mode of the treatment. So more of the patients are recommended for weekly Nab-Paclitaxel rather than tri-weekly regimens. So conclusion, NABUCCO study results confirm previous clinical trials outcomes, the favorable benefit risk profile of Nab-Paclitaxel, and sustained global quality of life in MBC patients in a real-world setting. Nab-Paclitaxel is effective and well tolerated both in elderly women and in the patient with the taxane refractory diseases. And the clinical data, a broader range of dosing and administration schedule, data suggests a weekly regimen is comparable in effectiveness and safety to the tri-weekly regimen. Physicians decided to use Nab-Paclitaxel in first line and later line treatment, and not only diseases. Adverse effects were generally rare and manageable with an unaffected quality of life. So NABUCCO study results may be used to refine treatment guidelines of the Nab-Paclitaxel with regards to administration modes, the treatment of the treatment lines in which Nab-Paclitaxel might be used, and studying Nab-Paclitaxel and other chemotherapeutic agents such as gemcitabine, capecitabine, carboplatin, bevacizumab, trastuzumab, lapatin, all has a better response to the treatment. And Nab-Paclitaxel plus antibodies, Nab-Paclitaxel plus chemotherapy plus antibodies, Nab-Paclitaxel plus neoadjuvant therapy, all have better response to the overall response to treatment, survival benefit, and less toxicity with good quality of life has been shown. And another trial, that is Nab-Paclitaxel in pre-treated metastatic breast cancer for evaluation of activity, safety, and quality of life, has been conducted in Italy in 2017. And it has been published in Oncotargets and Therapy Journal in 2019. So the main aim of this study was to evaluate Nab-Paclitaxel in Italian patients with MBC. And it was a retrospective analysis of 90 patients with histologically confirmed diagnosis of MBC, overall survival, progression-free survival, and overall response rate were the primary endpoints, whereas CA 15.3 reduction and quality of life and tolerability were the secondary endpoints. And the median overall survival was 10.4 months, whereas median progression-free survival was 6.8 months. Considerable difference in the CA 15.3 before and after treatment was observed. Association between the CA 15.3 response and overall survival demonstrated good correlations. And in conclusion, Nab-Paclitaxel is an effective and well-tolerated treatment of patients affected by the MBC. The drug showed an improved and tolerability profile. So this is an interim survival analysis. Last follow-up in December 17 was done, where this Kaplan-Meier plot of median survival has shown 10.4 months, where in progression-free survival was 6.8 months. So in conclusion, the Nab-Paclitaxel is an effective anti-tumor drug in the first-line treatment of metastatic breast cancer. Nab-Paclitaxel could significantly improve efficacy with comparable toxicities in the treatment of MBC. Using Nab-Paclitaxel instead of soluble-based taxanes could significantly improve overall response rate, disease control rate with comparable toxicities and dose discontinuation rates. With this, I would like to conclude my. Hello.
Thank you, Dr. Sachin, for a wonderful presentation. Like, it was really nice hearing about the effectiveness and safety profile of Nab-Paclitaxel in metastatic breast cancer. So our next speaker, Ajit, am I audible?
Yes, sir, you're audible. You're audible.
Okay. So our next speaker is Dr. Ambudkar, and he's working as a consultant clinical oncologist in Biro Hospital, and he'll be discussing about the effectiveness of Nab-Paclitaxel in pancreatic cancer. Over to Dr. Ambudkar.
Thank you, Dr. Guru, for the nice introduction. So I think time at light. Not being able to. Okay, I will take few minutes. So, thank you, Dr. Kunal, an opportunity to be here today. It's really my pleasure to be here. And the topic a little bit. So, I will be talking more. Am I audible?
Yes, sir, you are clearly audible. Please
okay, thank
give
you.
your PPT on full screen.
Yeah, I will just change a little bit of my topic that so we're talking about pancreatic cancer and systemic therapy in that and what to choose. So that will include, I will try to include the first line chemotherapy, second line chemotherapy, and few things about mutation in the pancreatic cancer. So to be honest, I will try to limit this talk to the histology only for the adenocarcinoma, total adenocarcinoma of the pancreas. And a few of the slides, wonderful slide I have taken from as education material from the PNSA Biotech. Thank you for that. But with that, I would like to disclose friends and interest. And I have used acronym PC that will stand for the pancreatic cancer. And to be honest, pancreatic cancer, though I'm not sure about what is the incidence of pancreatic cancer in Nepal or in India, common. And I think every month I see 3 or 4 cases of pancreatic cancer every time. And most of them at the metastatic stage. As from the CA data, we can see that at presentation, about 50% of the patients are in the metastatic stage where cure is not possible, and less than 20% patients present resectable stage. So this is the true scenario, even the past many years about the management of the pancreatic cancer. So just talking about cancer, but I will just try to focus on what is the role of chemotherapy in pancreatic cancer. Well, so it is indicated in all the stages of pancreatic cancer. Remember, so this is the one message that I would like to give. I hope everybody knows this, but I would just like to highlight these things. So take an example of, suppose for the breast cancer or the lung cancer, after surgery, we see tumor size or lymph node status, lymphatic invasion, and all of these. But for the pancreatic cancer, even it is a T1N0, there is evidence that adjuvant chemotherapy is always indicated. So we do not go for we do not go for the histopath examination looking after if there are any of those high risk features like I have already mentioned about we do not go for sorry, what I mean to say that there is no any condition in pancreatic cancer sector that adjuvant chemotherapy can be avoided. So all the patients receive adjuvant chemotherapy. So chemotherapy effective for the locally advanced pancreatic cancer, whether it's a borderline resectable or maybe some part of the encasement of like superior mesenteric artery, celiac situation. If it's a locally advanced pancreatic cancer, we can go for the neoadjuvant chemotherapy followed by the surgery and maybe or again chemotherapy something. Even for the recurrent or metastatic pancreatic cancer, it is always indicated chemotherapy for the pelvic cancer. What is the most important, remember, is the performance status. That is the most important part for the managed pancreatic cancer. As we will discuss in the slides to come, that whenever there is what we have to look after is the performance status of patient. If the patient has a good performance status, we can always go for the chemotherapy. So this is one of the slides I have taken for the NCCN guideline. This is a recent one. For the resectable pancreatic cancer, post-operative adjuvant therapy, the modified FOLFIRINOX or Gem plus capecitabine. This is the preferred regimen for post-operative adjuvant treatment. Or maybe 5-FU leucovorin. As I've said that if the status, we can go for the FOLFIRINOX or modify FOLFIRINOX or GEMS cap. But if the patient has poor performance status, then maybe single agent, maybe the capecitabine or 5-leucovorin can be an option, and there are other options. But to be honest, there are no much drug active for the pancreatic cancer. Just the few of them like 5-FU, gemcitabine, capecitabine, all of these things. Even for the locally advanced pancreatic cancer, resectable or unresectable. So if they receive, if they have not received any, if they have prior neoadjuvant therapy, so again we can go for a lot of things like chemotherapy, chemoradiation, all the things. But here again, what I would like to focus to draw your attention that if you see this NCCN guidelines, this is for the
Sir,
if patient have not
Dr.
prior
Ambuj,
neoadjuvant therapy.
Dr. Ambuj,
Yes, please.
sir, are
Yes,
you
please.
seeing PPT on your screen?
It's not visible.
Yes, on our screen it's not visible. Dr. Saha, are you seeing the screen of Dr.
No, no.
Ambuj?
Sir,
Yeah.
Actually, I was
Dr. Ambud's
expecting.
his screen is visible. I could see his content of laptop, but the slides are not
Yeah.
visible.
Sir, can you put this, because we can see the folder. We can see the folder. So you open the PPT and put it. Can you re-upload, sir?
I'm not. Is it visible now?
No, sir. We can see your folder.
अम्बुजलाई यसो गर्नु न, तपाईं त्यो PPT मा प्यानक्रियाजमा टिक त लाउनु भयो है, शेयर गर्नु भएको छैन कि शेयर गर्नु न.
No, sharing. I'm sharing my screen.
No, we can see you. I mean, we can see your PPT.
We can see your desktop and folder completely, but PPT is not coming up.
Just open, keep the PPT
Yes,
open.
yes.
Yeah, now
Yes,
it's okay.
yes, it has come.
Sorry. So
Yeah, make it full
not
screen and continue.
since the beginning, not coming since the beginning.
Yes, it was not visible when I started to
Okay, now-
project the screen.
now-
Yeah.
Okay, is it visible now?
Yes, very well. Please continue, sir.
Okay, thank you. I will just like to that whether patient has received therapy or not. After surgery, all in the pancreatic cancer. Second message, even after patient comes to the surgery, it's always we should always go for the guidance. All of they recommend that after surgery, again patient has to go for the staging. So important message that I would like to convey to you all. So option first line therapy or second line therapy locally pancreatic status. If patient in the good performance status or patient in the poor performance status. If the patient is a poor performance status, maybe single agent will be an option. But if patient is a good status, always the preferred one is the FOLFIRINOX or modified FOLFIRINOX, or maybe the here comes that gemcitabine. So what I found that in my practice or my experience is that both whether you use modified FOLFIRINOX or paclitaxel, both are equally effective. They have almost the same they have almost the same efficacy. I found that, but modified FOLFIRINOX is about again paired with gemcitabine plus Nab-Paclitaxel. Second line options again depends upon what the performance status of the patient, whether good performance status or poor performance status. Again, the same thing are there. But again, I would like to attention that I will go back once again. Even if the patient has the BRCA mutation, in those we can see that platinum-based chemotherapy I cannot find any role of the cell in the patient having BRCA mutation. Beautiful one. So whenever we have patient with a local induction chemo, the third point that I would like to highlight to all my colleagues that induction chemotherapy does not mean that for 6 months, suppose at least for 12 cycles. If you go for the FOLFIRINOX, then we have to go for at least the 12 cycles. Then only you can go further and restaging with CT. We have to also go for the tumor markers like CA19.9 response, because there are few studies have shown that increase in CA19.9 after neoadjuvant chemotherapy, they do good. If there is the worst or progression bridges, definitely if there is, we have to go for the second line chemotherapy or maybe the basic care. If there is non-disease, if maybe there are the non-progressive means that either there is a partial response or maybe they are not produced the disease. We should always go for the extra laparotomy, but because imaging may not be good to differentiate it, especially for the FOLFIRINOX or the Nab-Paclitaxel chemotherapy. Sometimes what we have seen that imaging show that there is no response segment, but when we explored there, we found that it could be resectable in 25 to 30% of patients. So this is also one of the very important message that I would like to say, that after going for the neoadjuvant chemotherapy, induction chemotherapy for the 6 months, we go for the restaging. If in the restage not progression disease, always you should try for the exploratory laboratory. Because what I've already said that Okay, this is what I've already mentioned. So again, just out of 47 chemotherapy, we should go for the restaging. Staging may underestimate the response to the chemotherapy, and that's one that CA99 is a poor prognostic factor if there is increase in this level, and sometimes decrease in CA99 may be a good predictor of resectability. So what are the different systemic options for the metastatic pancreatic cancer? Again, for the first line or maybe second line, whatever it is, depends on the performance status of the patient. If the patient is having status, one of the following we can go for immediate clinical target systemic therapy, or if the patient is poor, patient is high poor performance status, so maybe the best supportive care alone or maybe the single agent chemotherapy can be the option. So again, the same slide here, the same regimens, most of the regimens, if the patient is that good status or poor performance status with a metastatic disease, first-line chemotherapy is again the FOLFIRINOX or maybe mode 5 FOLFIRINOX or paclitaxel and gemcitabine. But if the patient is having the BRCA1-2 mutation or PALB2 mutation, then platinum-based chemotherapy, either with the oxaliplatin FOLFIRINOX or maybe the cisplatin-based gemcitabine cisplatin. These are the recommended regimen in the BRCA1-2 or PALB2 mutation. Again, the same thing. Second line, we do not have much to offer. So if there is fluid with a FOLFIRINOX or modified FOLFIRINOX, or maybe patient had already Nab-Paclitaxel, then and gemcitabine, then we have other options like 5-FU, liposomal irinotecan, or maybe sometimes again if capecitabine or xaliplatin, all these conditions. If the patient is in poor performance status, maybe gemcitabine single agent or fixed dose can. I'm not going much detail about if there is what is deficient MMR or MSI. Those are the conditions where you should go for the pembrolizumab. These are the only useful only in certain situations where they can be useful. And similarly, we can go for the entrectinib if the patient is having actionable driver mutations. So these are coming up, but I have no experience of using this larotrectinib or entrectinib in my patients. So this was one of the earlier publications which established the role of Nab-Paclitaxel in patients with metastatic pancreatic cancer, and it concluded that the drug showed an improved tolerability, and it was a good having good efficacy, and the median overall survival with Nab-Paclitaxel in metastatic pancreatic cancer was found to be about 8 months, and the median progression-free survival was 5 months, and the toxicity was almost manageable toxicities. There are lots of trials, but to be honest, most of these trials, or maybe almost all of these trials, are only phase 1 and phase 2 trials, and few of them are respective trials. I think I reckon that Dr. Sachin has already mentioned about few of these trials. So we can say that many of trials are there, which included Nab-Paclitaxel and gemcitabine. So few were the single arm trials, and few compared with other regimens like gemcitabine, capecitabine, or the FOLFIRINOX. So these are all trials. We have more than 45 patients in all these trials, and with for this NAB plus gemcitabine, you can see that median overall survival ranged from 11 to 12 or 13 months compared with the other, like here, this Cartwright trial, this was 2014, it was a respective trial. They compared Nab-Paclitaxel plus gemcitabine with gemcitabine and other chemotherapeutic agents. So we can see here that the median overall survival was better, that is 10.2 months with Nab-Paclitaxel and gemcitabine. There are many trials going on here, in the phase 2 and phase 3 trials going on for the locally advanced pancreatic cancer, but till now, what we can say that Nab-Paclitaxel and gemcitabine effective regimen for first-line treatment of metastatic pancreatic cancer. And these are the different ongoing trials going on, phase 2 and phase 3 for locally advanced pancreatic cancer. And to surprise what I mentioned, that one of the trials have got their outcome as resectability, whether that's most of the trials have put their primary outcomes over survival or progressive survival. So definitely this trial will be interesting, the NeoLab trial, will be interesting to see what are the results going on, because multi-centric trial, and they're comparing gemcitabine plus nab-paclitaxel with FOLFIRINOX, and whether giving gemcitabine nab-paclitaxel increases the resectability in locally advanced pancreatic cancer. The result are awaited. So just few slides about the BRCA mutation in pancreatic cancer. So what are the different studies have shown that about 10% pancreatic cancer arise from the inherited syndromes related to somatic alteration, and among these, one of these alteration influence in the mutation BRCA2 genes. So what BRCA2 mutation, if there is BRCA2 mutation, what happens that it impairs DNA damage response. So it is found that in the DNA strand exchange, the milestone is RAD51 protein, which is closely related to other tumor suppression genes like TP53, ATM, BRCA1, and all those things. And this BRCA2 is essential for repair of double strand breaks by recombination. So whenever there is BRCA2 alteration, there will occur that elevated level of P53 and P21 expression. There will be a spontaneous accumulation of chromosomal abnormalities, evident chromatic exchange. So this probably suggests what is the tumorigenesis in pancreatic cancer when there is BRCA2 mutation. So studies have found that BRCA2 can be used as a predictive biomarker in pancreatic cancer. So they can be considered as a biomarkers of genetic instability and DNA repair deficiency. It can be used as a predictive biomarker response to therapy, especially when we can see that for if there's mutation, the DNA damage, recognition of DNA damage is lost. So for those, maybe the DNA agents like platinum-based chemotherapy could be the better. So what we have seen, the lot of this, if there is BRCA2 mutation, that platinum-based chemotherapy is better than other things like FOLFIRINOX that contains the oxaliplatin, or maybe the gemcitabine and cisplatin. So what are the different recommendations for the patient having the BRCA2 mutation? Include FOLFIRINOX, modified FOLFIRINOX, gemcitabine, cisplatin. So this is what I have already mentioned. Similarly, for the unresectable BRCA mutation positive local pancreatic cancer, we have the fourth line and second line therapy, but there is no third line therapy. So in the fourth line therapy, again, INTERIM, they appear to be the best option is the fourth line chemotherapy. So maybe the platinum-based chemotherapy, but we have got some PARP inhibitors which is coming as the second line therapy. But I think there are a few trials going on that PARP inhibitors, especially olaparib, can be used as a first-line therapy if there is unresectable BRCA mutation. So in the again, first-line chemotherapy is the platinum-based therapy. In the second line, maybe the treatment Jameson Paclitaxel, or maybe alertinib or capecitabine, all the things. In the third-line therapy, so, we are not sure, but maybe the single agent gemcitabine can be an option. So this is the beautiful algorithm, but I don't see whether it's clearly visible or not. So whenever we have the unresectable ductal adenocarcinoma, we have to see whether it is locally advanced or metastatic. So once it's there, then anti-metabolite plus radiotherapy is an option. Like if they have the BRCA1, BRCA2 mutation in the first line, we can go to anti-metabolites. In the second line, we can go for the PARP or maybe oxaliplatin-based chemotherapy. In the third line, oxaliplatin, 5, all the things. But if there is metastatic and there is BRCA1 mutation, so gemcitabine and nab-paclitaxel find its role here somewhere. So this is the one of the organ that we can use. So I think I'm about to conclude my talk. So before I thank you all, just I would like to summarize few of my points that pancreatic cancer is very notorious disease, and this is the only one of the disease that I know for the all stages of pancreatic cancer, whether it is resectable, unresectable, or metastatic, chemotherapy is always indicated. Second point is CT imaging after neoadjuvant therapy may be sometimes underestimating the response. So it is always better to go for restaging, that is imaging again after the neoadjuvant chemotherapy. And if there is non-progressive disease, always try to go for exploratory laboratory. So these are my take from today's talk. Thank you for patience listening.
Thank you, Dr. Ambus, for your wonderful presentation. And I guess we all are enlightened about the effectiveness of Nab-Paclitaxel, pancreatic cancer. And as Dr. Ambus has mentioned, it's really a sorry, sorry for that. Dr. Ambus has mentioned it's really a notorious disease, so we should be careful when we are planning for any treatment. And our next session will be panel discussion, and I'll be moderating the session. And our panelists are Dr. Vivek Acharya. He is working as a consultant clinical oncologist, and also he is head of department of clinical oncology department of NAMS. And Dr. Pradeep Nepani, he is working as a consultant radiation oncologist in department of medical radiation oncology at BPKMCS.
Hello.
So I'll just
Hello, namaskar. Good evening.
Hello, Dr. Guru.
हजुर
ए हजुर सर कन्टिन्यू गर्नुहोस्
म यहाँ एकछिन फाइल अड्कियो कि
ओके
Dr. Guru.
हजुर
Meanwhile, while you are uploading your slide, okay. So I think Dr. Vivek is there, Dr. Pradeep is there. Both of them.
So
I'm here.
Okay. Okay, it's fine.
So let's begin our panel discussion, and it's about today we'll be basically discussing it's a case-based discussion, and we'll not be discussing any data or any other studies because Dr. Ambud and Dr. Sachin has already highlighted most of the topics. So I'll switch to our case. So our first case will be the metastatic pancreatic cancer.
Dr. Guru, are you having your PPT?
Yeah, it's being shared.
Sir, it's not visible. Your
Guru,
folder is visible.
It's not been shared. Not been shared
Okay.
yet. I think the same problem that I had.
Okay.
Yes. Sir, please open this PPT folder again and load it.
Just click your slide once again.
Yeah, sir, your screen is visible to us, so we can see your entire folder.
Guru, just double click pancreas. What is your this case presentation? The slide PPT.
Oh.
Double click there again. Have you started sharing?
Oh,
So,
I
yes,
started,
click,
but I
click
know
again. Yes, click again. Double click again. It will come, and then you have another window. From there you can share.
I don't know if I'm having some issue with this.
So just double click on the presentation, it will get open. It is not yet opened.
Guru, double गर त्यसमा के double click गर त
अनि डबल क्लिक गरेकै हो यो के भइरहेछ यसलाई
गर फेरि गर आइराछ हो आउँछ अब ल डबल क्लिक गरेर तल शेयर भन्ने आउँछ नि त्यसमा जाऊ त मेरो पनि त्यही प्रब्लम भएको हो किन
यो
or maybe you can
you are
can
sharing
you
screen
send
बनाएर यो शेयर
आइराछ नि you just stop or pause sharing, go back again. So can you send the slide to me, or maybe
Sir,
can host do it from there?
If there are no changes, then I can share. Dr. Guru, can I
that's okay. There was minimal changes, so you can say that won't be issue.
Okay, I think that will be a better idea.
Okay, yeah, please you share.
So good, you have unshare your screen first.
Yeah, we stop sharing.
So have you tried double clicking on your folder? Dr. Guru,
Yeah,
have you tried double clicking on the PPT?
Yeah, I tried that, but I don't know why it's being shared to me only.
Okay.
Hello, everyone. Hello.
Ajay.
If it is okay, can I leave, Dr. Guru? Because I have to go to pick my wife in another hospital since it is raining and windy outside. So she is waiting for me.
Okay.
Okay. Thank you all.
Sure.
Okay. Thank you all for.
Yeah. Thank you very much, sir. Thanks.
Thanks, Panacea Biotech, and bye, everyone.
Yeah. Thank you, Dr. Sir. Thank you so much for being here.
Take care, sir. Bye-bye.
Bye.
Okay, now we can continue.
Pallavi, you have to just open the presentation so that the panel discussion can be on.
Sir, it is not shared? It is not visible?
Not yet. Only your desktop is visible.
No. We can see your folder only. The screen has not been shared yet. Please share it.
Okay.
Is there any problem with this file only? Because
is it visible now?
Okay, now it's visible.
Yeah, it is visible. It is visible.
So, is it possible for me to take the control of the slide? Or?
Yeah, it is possible, Dr. Guru. But Pallavi has to give you the command. Pallavi, can you make Dr. Guru a host?
Just a second, sir.
Oh, I guess it's done now.
Sir, have you got it?
Yeah. Okay, thank you, Pallavi.
Okay, thank you, sir.
So, our first case presentation like metastatic pancreatic cancer, the patient with ECOG2, and basically this case depends on the paper published in oncology letters, and with the title Nab-Paclitaxel plus gemcitabine as first-line palliative chemotherapy in patient with metastatic pancreatic cancer with Eastern ECOG group 2 performance status of 2, and paper was published in March 2015. So our case is like 61-year female patient from Spain, and she was diagnosed with invasive lobular breast carcinoma stage 1, and she was like hormonal receptor positive, BR2 negative, and Ki67 was 60%. So she had undergone right radical mastectomy with lateral axillary lymphadenectomy, and none of the lymph nodes tested positive. So she received adjuvant chemotherapy with 4 cycles of intravenous A+C regimen, followed by estradiol for 5 years. She was doing all right, but in June 2020, she she developed a nodule in pancreatic head, and the CT was done with echoendoscopy. We showed that there was a focal hypodense lesion measuring 2.5 centimeters in diameter at the junction of body of neck and pancreas, which was closely attached to the portal supramesenteric and splenic vein confluence. And there was a small lymph node, CN 19.9 was elevated, and it was 62. So yeah, I would like to take some suggestion from our colleague, like Dr. Pradeep. How often do you find like a female patient she's under follow-up and you find some nodule in pancreatic region? So how often do you find this?
We'll find rarely, not very commonly, but only occasionally we can find this type of cases.
Yeah, as per my knowledge and as my clinical practice, I think I haven't find any patient like breast cancer patient having a nodule in pancreatic region. So
Yeah.
how would you proceed for further investigation in this type of case? Would you like to would you feel that this is a kind of metastatic region, or this could be a new or second primary in the pancreas?
We should have to go the biopsy confirmation for these cases. Otherwise, in the CT only, we cannot find the diagnosis.
Right. So like even this patient underwent like FNAC from the lesion, and it showed that the pancreatic adenocarcinoma. So the patient was treated at second primary for CA pancreas, and the patient received chemoradiation therapy and chemo. It was gemcitabine based chemotherapy, 1000 mg per meter square, day 1, 8, and 15, and response evaluation was done. And after response evaluation, patient underwent complete pancreatectomy, splenectomy, and vascular portal resection. So we don't have any surgeon, but I guess Dr. Vivek. Vivek, oh, no. So patient underwent surgery after neoadjuvant chemotherapy, and patient did good with post-operative status. There were no ADR observed, and in February 2021, the post-chemotherapy PET-CT didn't reveal any evidence of disease and except vascular thrombosis, for which the patient was treated with enoxaparin. And so, Dr. Pradeep, how often do you give any adjuvant chemotherapy in these cases?
Yeah, in the most of the cases, in the post-op cases, if the patient did not receive adequate neoadjuvant chemotherapy, then we can advise for post-op chemotherapy.
Yeah, but patient underwent. Sorry, please.
For these cases, how much cycle of neoadjuvant chemotherapy I received, I don't find.
I guess there was 3 cycles.
Only 3 cycles. Then we have to go the adjuvant chemotherapy also.
All right. Okay, so this patient didn't receive any adjuvant chemotherapy. So, patient was under regular follow-up, and in 2013, like the patient presented with intense lumbar pain, and patient underwent CT test and abdomen pelvis, which showed a sclerotic lesion in L5 vertebra. So bone biopsy and PET CT like confirmed moderate differential adenocarcinoma of pancreatic origin. So it was basically like patient developed bone mets which was pancreatic in origin. So again, this is like rare. How often, like you have a patient of pancreatic cancer and they present with any sort of bone met?
As pancreatic cancer is rare, I've not find any cases till now.
Right. So it's really rare we find like any pancreatic cancer presenting with bone met. So this patient was treated with zoledronic acid and followed by palliative radiotherapy. So bone pain was improved. This is the lesion that I was shown.
Yeah. Can you see that lesion again?
Sure.
Yeah, there is two lesion is clearly visible.
Yeah, it's like pulmonary. Patient later on developed like pulmonary nodules.
Dr. Guru.
So like, Azur.
Sir, if you allow me to pass.
Sure, please.
Okay, thank you, Dr. Guru, for letting me in here. So definitely, as you and Pradeep have mentioned, that pancreatic cancer is this is rare, but what I see that I won't say it's rare on, because it depends on your practice, how often you see, how many patients you see in a month or year pancreatic cancer. So you have beautiful lady, I think she's from Spain, the lady. I hope this is the actual case, that why they have Spain from the Spain. So few things are here. Bone metastasis is one of the common thing that I have seen in pancreatic cancer. Many patients pancreatic cancer ultimately develop bone metastasis, and they have very severe pain. And to one diagnosis involved, so those things required. And I would just like to emphasize one thing is that this thromboembolic event is one of the commonest symptoms in pancreatic cancer. Saying in other way that pancreatic cancer is one of the common cause of thromboembolic event. So when we treat pancreatic cancer, we always think that patient might need inexoprime or all the things that she has rightly received. So we always should keep in mind, somebody with pancreatic cancer, the chances of thromboemboli is very, very high. So it's better to put thromboembolic prophylaxis in the pancreatic cancer patients.
So, according to you, like you recommend all the patients to have any sort of like enoxaparin or aspirin to it's like prophylactic, or suspecting any patient like.
Okay, the different guidelines. BT is common cancers, especially in the pancreatic cancer. So they recommend for prophylactic enoxaparin or maybe anything low molecular heparin in the cases of if there are chances of high. Pancreatic cancer is one of the cancer where the BT is very high.
Okay, then we'll move ahead.
Please continue.
So, like this patient considering metastatic received gemcitabine at 400 mg per meter square with Nab-Paclitaxel at 50 mg per meter square. So, gemcitabine and Nab-Paclitaxel dose both are reduced here. So, like, how often do you practice this kind of reduced dose, the rhombus? Dr. Pradeep?
Yeah, we are not seen such a reduced dose in the.
Yeah, but it's like November 2013, so long time back.
Yeah. Maybe patient's performance status is poor.
Right.
Better they should give single agent.
Right. So following second line chemotherapy, there was a stabilization of the bone lesion and abdominal lymph node. There was no pulmonary meds. This is the graph showing the CA 19.9 level. It was like after first course of radiotherapy, it was sharply decreased, and then when the patient developed bone mets was high, and slowly with them Nab-Paclitaxel it decreased. So earlier Dr. Ambuz has also mentioned that CN 19.9 is a good marker to see the response of chemotherapy. So like Dr. Pradeep, how often, like do you go in every cycle, like you monitor CN 19.9, or you go for 2 or 3 cycles?
We'll go after 2-3 cycles.
2-3 cycles. Dr. Ambuz, how frequently you monitor CN 19.9?
Usually go for maybe as that I maybe after 2 or 3 cycles. Okay, doubt that patient is progressive, then definitely I would earlier. Just see, it's not only the tumor CN99, but all
Pisha? Yeah.
Okay, so the discussion of this part of case is like the present case report demonstrate the efficacy and safety combination of Nab-Paclitaxel plus gemcitabine, and isolated bone metastasis in pancreatic cancer is uncommon. So therefore, in the present study, the malignancy and origin of bone lesion was confirmed by biopsy prior to the treatment. So in breast cancer, most of the cases we find bone mets, but like in this case, we have to confirm whether the origin of bone mets was from pancreatic cancer or breast cancer, for which the patient underwent biopsy. And for this advanced pancreatic cancer radical surgery, as even Dr. Ambuz has well illustrated during his presentation, like in pancreatic cancer, after a certain cycle of chemotherapy, you need to evaluate the case for radical surgery. So in this case, also the patient underwent surgery. Also, with regard to chemotherapy treatment option, there are 4 different treatment options, like gemcitabine or gemcitabine plus olutasidenib, FOLFIRINOX, or Nab-Paclitaxel plus gemcitabine. And ultimately, like this pancreatic cancer is an autoimmune disease, so patient died in April 2014. So, Pradeep, like these are only the modality of chemotherapy regime you use for pancreatic cancer, or like in later cases you do you change or you modify some other regime as well?
Yeah, these are the common chemotherapy agent.
Yeah.
Most of the common I used is only this.
Okay. Dr. Ambuz, like how often do you use FOLFIRI or FOLFOX? Because in most of the cases, like FOLFIRINOX is really toxic for the patient, and like most of our Nepalese patients, they do not tolerate. So, can you share a clinical experience?
I got disconnected. Suddenly my internet went in between, so I couldn't get you. Sorry.
Okay. So like these are the common regime, like gemcitabine plus olutasidenib, or FOLFIRINOX, Nab-Paclitaxel plus gemcitabine. So like FOLFIRINOX is good in pancreatic cancer, but it's really toxic, So, and most of our Nepalese population, like patients, they do not tolerate this. So do you modify FOLFIRINOX to maybe FOLFIRI or FOLFOX, or you stick with FOLFIRINOX?
Okay, it depends on, definitely, if see how the patient is doing performance status. If patient is a good performance status, intention is that whether we can convert into resectability, then definitely I go for the FOLFIRINOX, this modified FOLFIRINOX. FOLFIRINOX is very much toxic. Modified FOLFIRINOX is less toxic. If the intention is not for the resection, then definitely I will avoid FOLFIRINOX. But definitely modified FOLFIRINOX will be the first option.
Yes, in the case of poor performance status, we can use gemcitabine and capecitabine in that place.
Definitely, those are also the options. Definitely.
Thank you. So,
But I have better experience with James capecitabine and erlotinib. I've used in a few locations. They have very good response. They are having stabilities for maybe more than 2 or 3 years. So if you have not used, I think you should try for capecitabine and erlotinib.
so like conclusion of our first case is like Nab-Paclitaxel plus gemcitabine combination treatment is a favorable treatment option with acceptable tolerance for patients with metastatic pancreatic cancer and other comorbidities. So we'll move to our second case. So our second case is like bone metastasis as primary presentation of primary ductal adenocarcinoma. So it's almost similar to our first case. So there was a paper published, it's like bone metastasis as a primary presentation of pancreatic ductal adenocarcinoma, and it's a literature review of the case reports. So our case is like so a rare case of bone vertebral metastasis from pancreatic adenocarcinoma, which appeared at the onset of the disease. So this was a 64-year-old man who presented with severe backache, and drugs were prescribed for pain control, but there were no really even the symptoms. X-ray showed mild lumbar right convex silicosis with signs of osteophytic spondylitis and vertebral discomfort, and like it was pain was aggravated at the level of 10, 11, and 12. Neurological assessment revealed that slight inferior limb numbness and weakness, mainly in the left leg, in combination with hypostasia and dystasia in the same region. Perennial reflexes were present. So CT showed that there was a bone refaction with D11 vertebral fracture and a spinal cord compression. And laboratory tests showed that there was CA was raised. It was 61 nanogram, while PSA was and beta 2 microglobin was normal. Even CN 99 points were normal. So this is the scan of the bone, and there was a vertebral biopsy was done, and it was like CKA E1 and E3 were diffusely positive. Simply in sample B, CKA and E3 were diffusely positive with metastasis of adenocarcinoma with acinar pattern. So like histopathological examination of vertebral soft tissue that led to the diagnosis of metastatic adenocarcinoma, and features were resembling pancreatic cancer. So this was diagnosed as metastatic adenocarcinoma of bone from pancreatic cancer. So Dr. Pradeep, like how would you proceed in the in such case? Like the patient is diagnosed with isolated bone cancer from pancreatic origin. So like there was no mass or some other issue with pancreas.
Yeah, in this case, a patient has bone osteolytic bone fracture with spinal cord compression. In this case, we should go to the palliative radiotherapy, as there is a spinal cord compression, and this is emergency condition, and we should preserve our knob. So we should go the palliative radiotherapy first, and then after that palliative chemotherapy, and zoltinic acid.
All right. So this patient with gemcitabine plus Nab-Paclitaxel in combination with zoltinic acid. And of course, like we are at the end of conclusion, but of course, the patient had to go for palliative radiotherapy, and like our discussion should be like pancreatic ductal adenocarcinoma. It's being the second leading cause of cancer death by 2030, with a 5-year overall survival rate of 7%. And as in other several solid and hematologic cancer, the tumor microenvironment and emerge as a pivotal driver of metastatic. Variable incidence of bone mets from pancreatic ductal adenocarcinoma has been reported in literature from 5 to 20%, but that has to be confirmed by postural overlapping between symptoms and other primary tumor and bone localization. So in this case, metastatic primary ductal adenocarcinoma with osteoblastic, osteolytic bone involvement of both right iliac wing and body of D11 and L3 vertebra, the main sites of bone prolongation in pancreatic ductal adenocarcinoma. So this case also suggests us that in case of pancreatic ductal adenocarcinoma, the bone mets is most of the case limited to D11 and L3, and a diagnostic biopsy was performed during the vertebroplasty, while the diagnosis of primitive pancreatic cancer was performed through radiological image. So, Dr. Ambudh, do you suggest any role of surgery in this type of case?
So I would like to go to the image. So here, okay, just a vertebral metastasis is not sufficient to say whether that is the way to be joint. So vertebra is a way to bury fracture in the fracture and having good for 6 months. Estimating kyphoplasty, those things should.
I guess Dr. Ambudh's voice is not audible. Dr. Pradeep, can you highlight on this?
Yeah, in this case, if there is a spinal cord compression with not, we should take the biopsy also in the same time. In that cases, we can go the surgery sometimes.
Okay. So, we conclude that the bone metastasis could represent the phenotypic expression
Connected
of
once again.
Dr. Ambudh?
Yes, sorry, I was disconnected once again. So, so definitely, surgery has got role. Is there definitely?
Okay. So we are at the end of our session, and the conclusion is bone metastasis could represent the phenotypic expression of underlying molecular pancreatic adenocarcinoma subgroup, but it's characterized by unfavorable outcome. So I think that was the common case that we see in our OPD, but with today whatever we presented was the uncommon presentation. And with this, I would like to thank Dr. Pradeep for sharing his experience, Dr. Ambudh, and of course Dr. Vivek is not feeling well today, so we missed his suggestion. And also like to thank Panacea Biotech, the maker of Paclitaxel, for their support in organizing this academic event. And over to you, Kunal sir.
Yeah, thank you very much, Doctor. I'm especially thanking to our speaker, Dr. Sachin Sakyam, who has started the session in the MBC with Dr. Ambudh, who has taken excellently about the pancreatic cancer. Thanks to Dr. Guru Sharan Saj. You have moderated the sessions along with the case presentation presented by Dr. Vivek and Dr. Pradeep. This is a really excellent interaction, and COVID pandemic has made us to come closer at the desktop without much travel, and the exchange of the knowledge is getting shared wonderfully well. Panisha Biotic is always there on the forefront to support and extend our all technologies which is available for the knowledge sharing on this platform. Now there are very selective webinars which is of interest in our clinical practice and which is enhancing, and our oncology BU is doing that well. Paclitaxel is one of the brand of first global generic equivalent to the originator, is well accepted, and each and every center across the country, those who are managing MBC, has used a Paclitaxel. So Panisha Biotic will keep on extending our support for all academic activities to the oncologists from Nepal. And for this, on behalf of Panisha Biotic, I request Srivastavji to have the vote of thanks. Over to you, Shailendraji.
Thank you so much, Dr. Kunal. It has been, and I really express my gratitude to Dr. Guru Sharan for moderating such a wonderful session. And vote of thanks to Dr. Pradeep, Dr. Ambuj, and Dr. Vivek, and especially Dr. Sachin, who is not here with us right now. And happily sharing that Nepal, last 1 year, we have seen a good usage of Paclitaxel, and I'm really thankful to you all for making this brand accessible to all the patients who are seriously requiring the therapy for metastatic breast cancer and pancreatic cancer. Since this program will not be completed if I will not invite my colleague Samudra and Bhushan to close the session, because they are basically more closer with the delegates than me. So over to you, Bhushan, to close the session. Thank you so much for giving us this opportunity. Bhushan, I will request you to kindly close down this session. Thank you so much to all the delegates.
Thank you, sir. And it was great help from Panisha Biotic also. And thank you, doctors, right from Dr. Sachin Sake, Dr. Ambuj, Dr. Pradeep, Dr. Guru, Dr. Vivek. And Dr. Vivek could not participate because of his health issue. So Dr. Vivek, we wish you a very speedy recovery also. And thank you all of you, and thanks for your valuable time given to us in terms of sharing your knowledge. And thank you so very much. And we hope we will like to continue this kind of event in the near future also. Thank you, sir. Here we close, and have a nice evening also, and happy Shivratri, sir.
Thank you for giving us such a wonderful opportunity. Thank you, Panisha Biotic.
Thank you, sir.
Thank you. Thank you.
Thanks, sir.
Thank you to everyone. Yeah, thanks. Bye. Have a good one. Bye.
Thank you, everybody. Thank you, sir.
Thank you, Pallavi. Thank you so much.
Thank you, sir.
You had been a big support for arranging this great webinar.
Thank you very much, Pallavi.
Yeah. Thank you, sir. Thank you.
As Bhushan has said that Pashupati Nath Ji is basically the God we love the most. So happy Shivratri to all of you there.
And thanks, Bhushan, for reminding Pashupati Nath. Thanks, Shailendraji, as tomorrow is a happy Shivratri. So it is a really very prompt and very relevant to remind Pashupati Nath. I remember that every time I visited the temple.
Yes, sir. Thank you, sir. Thank you so much. Thank you so much, everyone. Have a wonderful evening.
Thanks.
Thank you all. I'm ending the session.
Yeah, thanks.